Good afternoon. Welcome to Ask Us Anything on Facebook Live. This is Dr. Bill Bird, Chief Medical Officer at CGH Medical Center. This is October 6th. Thanks for joining me today. Let me give you the roadmap of how today is going to play out. So I have some information to share about COVID, and that won't take a lot of time. And after that, though, I'm going to do some shout outs, and then I'm going to kick it off to actually this week. I pre-recorded a session with a couple of our physical therapists. So we're going to talk about our rehabilitation department and some things going on there. But before we get to that pre-recorded, I want to start here and talk a little bit about COVID. So first of all, I want to throw out the 1918 flu as an example of something just for us to be aware of. So 1918 flu obviously hit really hard in 1918, but there kept being surges of that through the early 1940s. And I say that just to say that it's pretty likely that some form of COVID is going to be around for a while. Will it be around that long? Don't know. But pretty likely something's going to be around for some period of time, which means that we're going to have to, and we are learning to live with that. Live with that reality, I guess you would say. And so the good news, though, with all that, though, is at least at this time, the current disease severity, so the likelihood of getting really sick with these particular variants is much lower than some of the original variants that showed up. So that is really good. Our community levels are going down, and our hospitalization rates are much lower than they were in the past. So all that is really good news at this time, which has allowed us to do some things because of that, and also because of some of the CDC recommendations. So here at the hospital, now with masking, we're making in common areas that masking is something you don't have to do, but you can if you want. We're asking that our medical staff mask when they're providing direct patient care, but otherwise not needing to do so. Now that could change as all these parameters that I was just talking about, if those change. But that's where we're at right now. We also have, because of those parameters, an option now for patients if they have symptoms that are respiratory type symptoms to test, do an antigen test at home, and then if that's negative, see their PCP on the same day. So it allows more patients to be able to get in their primary care offices. And finally, we have, as of this past Monday, stopped doing preoperative COVID testing for patients who are going to have elective procedures here at the hospital. So all those things are really good news. It's nice to walk around the hospital right now and see all their faces. So it's been a good thing. Wanted to share just a few data points with you of some recent research and information. So Journal of American Medical Association, kind of one of the, for those of us in the medical profession, one of the premier journals came out with an article recently that said they did a study that from January to April of 2022, which was basically during that original Omicron variant surge, your risk of being hospitalized was 10.5 times higher if you were unvaccinated compared to someone who was fully vaccinated. And your risk of hospitalization was 2.5 times higher if you'd only had 2 of the vaccines and hadn't had the booster. So obviously, at least for that Omicron variant, that was very helpful in terms of getting that. It doesn't prevent you from being hospitalized or getting real sick, but it reduces your risk. You may have seen something in the news today that's just kind of running some numbers too about the current variants. And, the most latest bivalent vaccines are targeted towards the latest variants. And so the projection is that if 80% of us who qualify for those vaccines could get them, it would save 90,000 lives, prevent 936,000 hospitalizations, and save $56 billion in the next 6 months if 80% of folks could get the latest boosters. So nothing has changed in terms of my recommendations to those of you who watch this program. Please get your boosters. If you qualify, it makes sense. They're safe. They do the trick. I suspect, as I said earlier, that this is going to be around for a while. And I suspect that every once in a while, a booster will come out to try to help reduce the risk of getting really sick. Take advantage of that. So I do that. And I also would get your flu vaccine. And if you want, you can get them both at the same time, but you don't have to. But I would get both of those. For myself, I had COVID early August. And so I'm waiting about 90 days, which would be early November. And I'm just going to get both then. So that's how I'm looking at that for myself. Yes. Oh, there we go. Thanks, Rebecca. So just some information about bivalent vaccines. And thank you, Rebecca. Appreciate that too. Just some times about flu and COVID vaccines. So take advantage of those. Obviously, local pharmacies have those also. And I wanted now also to do some shout outs, celebrate some folks that work here at CGH. So I'm going to have Rebecca put a few of those up on the screen if she would. First of all, Holly Hilty. Holly is our employee of the month. Holly works in our behavioral health unit. She's a nurse there. Holly does a great job, and excited to have her as our employee of the month. Congratulations to Holly. Next shout out. Oh, yeah. So this is National Healthcare Food Service Week. So the folks that work in our food services department, want to give them a shout out because this is their week and they do a great job. We have really good food here at CGH. So thankful for them and thankful for all the work that they do. What other do we? Oh, yes. So this is October is Breast Cancer Awareness Month. And just want to highlight our 3D tomography or mammography that we have here at the hospital. And we have year-round screening mammograms with no out-of-pocket cost. You can read the fine print there. But basically, our health foundation, our CGH Health Foundation, helps to make up the difference of cost for folks who are getting their mammograms. So we really want to make it affordable and easy for folks to get their mammograms here at CGH. And this is October is Breast Cancer Awareness Month. And I wanted to give one other shout out too, and that is this is healthcare supply chain week. So to our materials management department, I want to give them a shout out. Yeah, anytime you've read the news, you've seen stuff about supply chain, and that has been such a big deal here at the hospital. And our materials management department, led by Mark Humphreys and Louis Camacho, have done a really good job of keeping us supplied with what we need to take good care of patients. And so I want to just thank them today. And this is their week too. So shout out to them. Okay. So that's all the work I needed to do right now. What I'm going to do here in just a moment is kick this to the pre-recorded session I had with Ali Yem Repass, who's a physical therapist in our outpatient rehabilitation department, and Drew Carroll, who's also a physical therapist in our outpatient rehab department. I had a chance to sit down and interview them earlier this week, and I think you'll enjoy the conversation that we had together. So without further ado, I do have a further ado. We're going to come back on October 20th, and we're going to talk about the work that we're doing here at the hospital to help women who have the diagnosis of breast cancer navigate that with some of the help that we have here at CGH. So that'll be October 20th, and that'll be live, and looking forward to doing that. Now, with no further ado, let's kick it to my interview with Ali and Drew. Hello and welcome to Facebook Live. This is Dr. Bill Bird, Chief Medical Officer at CGH Medical Center. Thank you for joining me for this recorded part of Facebook Live for this week. And I am happy to be interviewing today both Drew Carroll, who's a physical therapist at our outpatient rehabilitation center, as well as Ali Yem Repass, who also is a physical therapist at our outpatient rehabilitation center. So that's the plan, to talk with them and kind of ask them some questions and get to know them and learn a little bit more about what our physical therapy department on the outpatient side does. So without further ado, let's get Drew and Allie on the screen. Hi, Allie. Hi, Drew.
Hello.
Welcome.
Thank you.
Thank you.
Okay. So, hey, by the way, before I forget it, happy October is National Physical Therapy Month. So happy Physical Therapy Month to both of you.
Thank you very much.
Okay. So in honor of Physical Therapy Month, we thought we would ask a couple of our physical therapists, namely the two of you, that by the way, Jeff Wright, who's the director, volunteered you two guys. So he must have felt like you were the best fit to do this. So I'm going to ask Drew and Allie several questions about physical therapy and give them a chance just to respond and tell us what they're thinking about those questions. So without further ado, here goes. This is for both of you. I want to run this by you. Can each of you tell our viewers a little bit about yourselves and how you came to choose physical therapy as a profession?
Go ahead, Allie.
Well, thanks for the welcome, and it's awesome to be on here. Thank you. So I grew up in Sterling, Illinois. One summer after college, I came back home, and I was helping kind of some church friends and out on a farm, and her husband had Parkinson's disease, and so I got to work with him quite a bit and really see what kind of impairments people with Parkinson's had, and how that really affected the rest of their family. That kind of got me tuned into neurological diagnoses and wanting to help in some way. Two of my older sisters, one is a neurologist and one is a physical therapist. So they really helped guide me on the path to be where I am now.
Okay, good. That makes sense. How about you, Drew?
For me, growing up in Lanark, a small town, you see a lot of local individuals try to help out themselves as much as possible. So they're always helping out the youth in that community. And I knew from a young age, I wanted to help out in some way. So for me, being pretty active and an athlete, it was easy to kind of steer towards an athletic field. I watched my brother go through 2 ACL surgeries, and his experience with physical therapy was a great one to get him back to doing what he wanted to do. So I knew that was probably going to be a pretty good calling for me. Started out with the athletic training side. We had an athletic trainer that I talked with and just discussed different options. And in the end, physical therapy seemed to be a better fit for what I wanted to do long-term, being more one-on-one care with the patient rather than trying to manage an entire team and a busy training room. So
sure, that makes sense. Good. Okay, great. Well, thank you. That makes sense for both of you. I want to ask Allie something now. So Allie, you recently received board certification as a neurological clinical specialist. So first of all, congrats on that.
Thank you.
How do you see this benefiting the patients you care for, Allie?
Yeah, so I see it benefiting the current patients by having a little bit more in-depth understanding of their neurological diagnoses, which really helps with evaluating, kind of looking for differential diagnoses, having a more specific plan of care that is really tuned into their neurological diagnoses. For instance, somebody with, Lewy body's dementia, or somebody that can't remember things quite as well, might have to do an exercise 1,000 times, where somebody with multiple sclerosis, it could be harmful for them to do something more than 5 times. So just having a much more specific plan of care throughout their exercises, their home programs, things like that. And also, as you know, research is always changing. And so in PT school, we learn at that time the most current clinical findings. But it was really great while studying for the board exam to kind of forces you to be up to date on the most current clinical practice guidelines. But yeah.
Okay, that's fair. I'm going to switch gears a little bit and talk pelvic floor health. Okay. So that's also something that our CGH rehab team treats patients for. what patients does this service seem to help out with the most, Allie?
Yeah, so I'm so excited that we have pelvic floor rehab here. It's actually helpful for everybody, any age, man, women, everybody. We've always been told that, you jump on a trampoline, it's normal to pee your pants a little bit, or to have
I
any.
haven't heard that actually, Allie. So
Okay, all right. Well, it's
okay.
so common, and people just kind of brush it off like it's normal, but it's not normal. And it's not normal to have pain in the pelvic region. And even oftentimes low back pain has to do with pelvic floor pain as well. So surely everyone's heard that, you should do a Kegel or something like that, but people don't usually know if they're doing them correctly. Are they using the right muscles? Are they using too many muscles? Are they overdoing it or potentially causing damage? This is where an in-person hands-on evaluation can be helpful, and that guidance with a skilled physical therapist that has done more education than just physical therapy school can be helpful. And we actually have some great therapists that do that here in Sterling, and Lindsay McBride now in Morrison does as well. I think we're so lucky to have that here, especially because it, so often people have to travel to a bigger city, Quad Cities, Rockford, and to have that here in Sterling and Morrison is pretty unique and cool. So
Yeah. So Lindsay does that, and then Pam Cap does that too, right?
yes, and Morgan Jacobs also.
Okay. So Morgan. Well, all right, great. So like that would be for folks who have, as you alluded to, some sort of trampoline-induced incontinence, or they have pelvic pain. What would be some other things, diagnosis-wise, would you say, Allie?
Even constipation or pain with intercourse, or actually, truthfully, it's also a safe place to ask a question that you can't just Google, or if you don't feel comfortable asking your MD. A lot of it is patient education. But yeah, incontinence, constipation, pain.
And both for men and women.
Yes,
correct?
most definitely.
Okay. All right.
For
Good.
all people. So.
Good. All right. I have one for Drew now. Thanks, Allie. So Drew, it's not uncommon for folks to walk around with really swollen legs. That's the fancy term for that. You and I both know is called lymphedema.
Correct.
And sometimes they'll have swollen arms if they've had something done as well. So all that's lymphedema. Can you talk a little bit about what our rehab team can do to help those individuals?
Yeah. Many times after a surgery or something of that sort, an injury, you'll start to see swelling accumulate. Swelling is pretty normal. Obviously, the body does that for a reason. It starts to bring those nutrients in to assist with healing. However, if we're not getting rid of excess fluid, then it starts to pile up and become an issue. You can push out and it'll start to harden in the skin, and in severe cases will start to weep through the skin. Things to look for, maybe even loss of range of motion, thickening of that skin, like I say. So Bree Hamstra is one of the main ones that leads this up in our department through the occupational therapy. And she does a series of treatments, including manual lymph drainage, which is essentially a massage that kind of helps milk that fluid back to where it needs to be. So if you can get that moving towards the heart, that can help get the fluid to discharge from the body. If that doesn't seem to be effective, then she can always progress into more advanced treatments using compression garments or compression stockings, different types of wraps. And then she also has pumps they can use, and then just active exercise. Truly getting gravity and active exercise can help get some of that fluid moving back to where it needs to be as well.
Okay, good. Yeah, good to know. And I just hope folks that are out there know, either if they have it or know someone that has that Bree is definitely a great option for folks to try to improve upon that. And I've never had really swollen joints, but like I can't only imagine. I mean, you're talking pounds of weight that you're trying to move around, and so if you can get rid of some of that weight, your ability to move has to be so much better.
Exactly. Yeah. It's pretty crazy to see how limiting it can become in those severe cases. So the relief that those patients feel, both from the pressure within the joint or the limb, and then just being able to get their mobility back, is very crucial to their functional capacity. So
Yeah, good. Good. Thanks, Drew. And I have one for Allie now. Allie, I wanted to run by you dizziness, particularly since you're a neurological, you kind of have some focus and emphasis in neurological stuff. So I know dizziness is a pretty broad complaint, but how can you kind of talk a little bit about how you and your team approach dizziness at CGH Rehab?
Yeah. So, Dr. Bird, this is something I'm super passionate about. Dizziness is such a broad term and so subjective. And really, what we do here is first things we listen to the patient and try to figure out what kind of dizziness they're explaining, because it's kind of this umbrella term. We kind of try to get an idea that way, but we still screen for other reasons for dizziness, including abnormal blood pressure or nutrition, lack of sleep, any kind of central reason, just meaning something going on with the brain that they might need to, go quickly, go see medical care next door or see a neurologist. And then the most common reason that we usually see or treat dizziness for is vestibular, which is this system. It's this organ that you have kind of deep inside your ear, and it tells your brain when you're moving in space. And so if that's not working the way it should, you can have this sensation of moving more than you actually are, or moving when you're actually not moving.
Okay.
And so we kind of work on retraining that and fixing that problem.
Yeah. And at least what I've seen, you have some interesting positions you put people in to help them with that. Is that correct?
Yeah. Lots of different maneuvers to,
Yeah.
that's a long conversation.
Yeah, right.
Yes.
I hear you. Good. Yeah, it's a fascinating thing, this dizziness, where it's like your ears telling your brain that you're here, right? But your eyes and your feet and everything else is telling your brain you're here. And your brain does not know what to do with that. And that's when this whole rotational thing starts to happen.
Yes.
So it can be very effective to see someone like Allie to help you with that, if that is an issue that you have. So, hey, Allie, let's keep on the neurological line of questioning. And I want to ask you a little bit about the Big and Loud program that is run through CGH Rehab. And I know you're a big part of that. No pun intended. So talk to me a little bit about both the Big and the Loud program.
Yeah, so the LSVT Big and LSVT Loud programs are specific one-on-one therapies for individuals that have Parkinson's disease to teach them to use their bodies in a more normal way. Individuals with Parkinson's often move slower or smaller, kind of shuffle, might speak very softly. Big is led by an LSVT Big certified occupational or physical therapist. And we address the patient's motor function. So think walking, standing up from a chair, writing, getting up from the floor. The treatment helps to improve those types of functions and teaching them to kind of recalibrate. So they might perceive that they're moving normally, but to the outer eye, it looks like they're moving really slowly. So we want them to use extra effort with what they're doing, which might make them feel like they're moving bigger than normal, but then it is perceived to the outer eye as moving normally. And the same goes with speech and voice volume.
Okay. Yeah. So I'm hearing that it's not uncommon for patients with Parkinson's disease to see you for that. Is that the main diagnosis you're seeing folks for that kind of program?
Yeah. So there's been research since the 90s for LSVT Big for individuals for Parkinson's. From what I know, there's not necessarily research showing that this particular therapy is helpful for other neurological diagnoses besides Parkinsonism type.
Okay. So you're really targeted to the Parkinson's patients. Okay. Yeah. So I'm just curious, so someone comes to you for that program. What are some mixed successes in terms of what you see folks in terms of their movement or speech, Allie?
Yes, it's really cool when somebody comes in and maybe they use a wheelchair or they shuffle in and they get out of the chair for the first time, or they can walk without shuffling. Those are our biggest wins. Some people come in and they can actually do a handstand. We have all different levels of people with Parkinson's. So I guess it's more specific to the patient, but
Okay. Yeah. And how long does that process take? Are they there for the rest of their lives, or they have a period of time?
great question. So because it is a research-based protocol, the formal LSVT big or LSVT loud therapy is 1 month. So 4 weeks coming to
Yeah.
therapy 4 times a week for an hour, and then they're
Wow.
expected to do 2 rounds of exercise at home each day.
Wow.
And I keep bugging them the rest of their lives because they got to keep up with it.
Okay. All right. So the package is they get a month, 4 sessions a week for a month, and then they get to be bugged by you for the rest of their life.
Yeah, random
Okay.
phone calls here and there, checking
Okay. Perfect. Yeah. I'm sure people will be all fired up about getting signed up.
in.
All right. Good. All right. Great. Well, thanks, Sally. And I'm going to move on to Drew. I have a question for him. Want to talk high school sports? You alluded to you participated in athletics and everything when you were younger, but so they're in full gear now. Got a lot of seasons going on right now, which means that injuries are in full gear also. So I want you to talk a little bit with the folks that are watching what CGH Rehab does to try to get these athletes seen and then returned to the sport that they want to participate in.
Yep. Yeah, definitely a busy time of year right now with football and volleyball and all of the fall sports back in action. Obviously, that means a lot of injuries to follow as well. So we've been getting some coming in here. We always try to make this as specific as possible. It gets pretty easy to look at the individual, but you got to remember the basics of what you're trying to see and treat. So breaking it down into what the deficits are that they present with. You always want to make sure that you're checking out your range of motion and your strength, your functional biomechanics. And though these might seem, kind of elementary, they're a definite piece of the puzzle as to what you need to do moving forward. Without knowing what those deficits are, it makes it pretty difficult to know what to treat. So day one is really getting to know that patient and just getting a really clear image as to what's going on with them and what maybe caused this injury to bring them to you. Once you have that, you start to go after those deficits through treatment, trying to get them back as strong as possible. And when you start nearing that return to sport phase, that's where things can get a little bit more challenging. Emotionally, these people have maybe been out of the sport for, say in an ACL, they've been out of the sport for maybe up to 6 months plus.
Yeah.
So bringing them back to trying to run can be a little bit of a confidence hurdle. We try to use different objective measures that we know through research show that these patients are ready to where they need to be. Typically, you want to see them get to that 80 or 90% plus range in terms of strength. For an ACL, we might do different strength tests or power tests for single leg hop, just different objective measures that show that that person is truly ready to start trying to get back to their sport. Shoulders, like in a pitcher or a volleyball player, can be a little bit more challenging, especially with pitching, because it's crazy how much the way their foot even contacts the ground when they throw, or their hip position, their core position, all these things play a really big role in terms of what that shoulder is doing through the throwing motion. So you really want to start looking at that as an entire picture when you get back to that return to sport phase, instead of just honing in on what the shoulder deficit was for the majority of that treatment. So yeah, that return to sport phase can be a little bit challenging, but through objective measures in our research, we know what we need to be looking at that phase.
Do you change their deliveries, like for a pitcher, like our
No, I try not to do as much of that as possible, just because that can start to, alter the way they've done things for a really long time. But if you can change the way they're striding out, change the way that maybe their hip positioning is when they're coming through that late cocking phase, things of that sort. But I try not to mess with the arm or the release point too much, because that can really kind of get in their head too. That
honestly, we could bill you like as a pitching coach or something like that, Drew.
Yeah, something like
that. All right, let's talk about knee and hip replacement surgery. So that's pretty common. A lot of folks, as the years go by, need to have that done. So we have now a total joint program that we're working with our orthopedic doctors and our podiatrist, Dr. Hanlon, Dr. Riley, Dr. Thormeyer, and your team, like a total joint program for patients that are coming to CGH to have their total joint replacement therapy or surgery done. Can you talk a little bit about that whole process now and how that flows for patients?
Yeah, this has been in my mind, a long time coming. This is a really good addition to what we do here in the outpatient side, for a lot of reasons. So many times these patients come in after having a total knee or say a shoulder replacement or whatever the case may be, and they are shocked at what's ahead of them for, what's to come for the rehab side of things. Getting them in ahead of time really helps calm the nerves, and let them know what this is going to look like for the next however long it may be. In the case of a total knee, 6 to 8 weeks. In the case of a shoulder replacement, maybe a lot longer.
Yeah.
They're pretty unaware of that potentially moving into it. So we get them in ahead of time. We like to go over what their home setup looks like and make sure that's ready for them for when they get done with their surgeries. Give them all the access they need or the contacts they might need in terms of how to get equipment for home, like shower chairs or toilet risers, walkers, things of that sort. Yeah. So it's really good to get them aware of what they're going to need going into that surgery.
And then I know that the inpatient team does work in terms of trying to get those patients mobilized as quickly as possible so that they can be discharged from the hospital as soon as possible too, right?
Yes. Yep. Yeah. So they are in with the patient pretty much right away after surgery that day. They're going to be in there working with them and trying to get them discharged to the correct place. So that can be a challenge as well, trying to decide where they need to go, whether it's back home if the home setup's right for them, or maybe to a skilled facility if that's more appropriate.
Yeah, good. All right, well, thanks. I wanted to talk a little bit with Allie about something called dry needling. So Allie, I know you're a dry needler. So tell us what that is and how you can help patients with dry needling.
So dry needling, it's a dry needle, just meaning that nothing is injected, nothing comes out of the needle. And it's used for treating tight muscles or knots, or we call them trigger points. That's the most common way we use them, but we can kind of get a muscle to calm down a little bit, kind of break up some of that knot before stretching so that we can help with some of the muscular imbalances. So after dry needling, we definitely do stretching, and then we address more of the bigger problem, like why is this happening? What's working harder than it should, or what's weak? But it can be helpful. It can be helpful for some of those people that the muscles just won't calm down, or they have those long-term knots.
Is it painful for patients to have that done?
Ooh, pain is subjective, Dr. Bird.
Yeah. Well, what range do you see in terms of folks when you do that?
Yeah. So sometimes actually people, are you asking if it's painful to have dry needling done or if it's helpful for pain?
Yes.
Okay. So sometimes people can't even feel when the needle's actually in. It is so small. But usually when those knots are hit, the muscle twitches, which on my end is successful, but it can be a little bit uncomfortable for the patient. Lots of people do it all the time though, and so far everybody's come out all right.
Okay, good. All right. Hey, Drew, I want to ask you something about manual therapy. I know that I think Nate Ackert and Jenny Adamson do that. What does that involve, this manual therapy, and who might benefit from their services?
Yeah, so Nate and Jenny took a very extensive manual therapy course series through continuing education. Manual therapy is a lot of just hands-on work. So this can mean anything from joint mobilization to manipulation. This could mean manual traction, just pulling to slightly separate a joint to provide some relief or some gapping to that joint. There's a lot of different sides to manual therapy. Just about anybody can benefit from that service. Those two have also gone on for the orthopedic clinical specialty exam, which is the orthopedic side of what Allie has accomplished as well, which is a really big deal for what those guys are doing. It's a lot of studying and a very difficult board exam, and then continued education moving forward to maintain those certifications. The biggest thing that both of those help these therapists and take away from it, and then they also help the rest of us in here through communication, is just what to kind of look for when we're treating. Can kind of streamline what we're trying to do, kind of helps you with differential diagnosis and lets you know what's appropriate, maybe what is going to benefit from physical therapy and what is not. So it helps you get right to the point and be able to be a little bit more efficient with those treatments. With the future of physical therapy kind of trying to move more towards a direct access approach, I think this is a really good thing, just because if we aren't seeing those results that we need, having the tools necessary to know if this is going to be beneficial or not can be a good thing to know if this patient is more appropriate to be referred to the medical doctor or some other specialty that might be more appropriate for the patient. So the manual therapy side of things has been very beneficial, but also just knowing what to do and where these patients might need to go instead is a bigger deal, I think.
Yeah. Good. Thanks, Drew. I want to ask both of you something. So we're kind of running short on getting towards the end of our time together. But, I know that rehab encompasses, obviously you all are really involved with adult rehab and outpatient side of things. However, our rehab department encompasses pediatrics as well as work done on the people who are in the hospital. I'm wondering if the two of you could kind of touch on the work that is being done in those other settings in our rehabilitation services department.
Go ahead, Drew.
All right. So on the inpatient side of things, they're working directly with patients who have been hospitalized for whatever the case may be. This is a very important thing because if you think about even when you're sick and lay in bed for a day, how debilitating that starts to feel, both with your strength and your endurance. You might even feel dizzy. So getting in and getting these patients up and moving as much as possible early and often is really beneficial. And then, like I said earlier, trying to decide where they might be most appropriate to discharge to, whether it's to home or a skilled nursing facility or somewhere with 24-hour care of some sort. So having the knowledge base to know what those objective measures are showing and where they are most appropriate to go is very important. The home side.
Hey, Drew, I'm sorry to interrupt. One other thing I forgot all about is that you guys also do home health care too, right? I mean,
Yes.
Some of those inpatient folks are doing home health care.
Yep. Yeah. So with the home therapy, obviously the resources become a little bit more limited because there's not a gym or there's not all the health equipment there. So that can present a real challenge for these therapists as well. They do a really good job with trying to make the most of the environment, show these patients what they can be doing at home to be most efficient with their healing and their return to function. So they're going directly in the home though. So that's a totally different setting than what we're doing.
Yeah.
On the pediatric side, obviously that's all kids and pediatrics, a very underserved population prior to developing this program just a couple short years ago. And it's really exciting to see that program grow. They've been able to help a lot of little ones in the area and all sorts of different conditions and just show these parents and the families what they can be doing as well to get them back to normal. So
good. I'm going to give you both a chance to do any shout outs you want to give right now. Anything you want to shout out here?
Yeah, I've got to give a shout out to our amazing speech and occupational therapists that we work hand in hand with. Again, from a neurological perspective, when somebody comes in after a stroke, sure, we might work on walking, but if they don't have the cognitive help from speech therapists, they're not going to get as much out of walking. You have to remember all of those steps. And also our occupational therapists are amazing with getting these people back to their activities of daily living. Also, I want to give a shout out to Julie Zeidema and Jeff Wright, who have been making such a great effort within the last few months here to really show that they trust us by giving us more autonomy and accountability, that showing that they trust us. And we've worked hard for, in school to be where we are. And I feel like this mutual respect has gone a long way with our productivity and kind of our day-to-day interactions with each other and our patients. So shout out to them.
Good.
Pretty much along the same lines, just in a little bit different way. Our staff here has been an awesome team. We all work together really well. I think we provide a really positive attitude, and I think that shows. A lot of the patients feel pretty comfortable after being here for a short while. So it's been a good thing to see us all work together and make a really nice environment here throughout the gym and in the office when we're all just hanging out, talking and tossing questions around to each other, as well as our management. Like I say, or like Ali says, they've been doing a great job to trust us and just keep putting it in our hands. And to this point, we've really appreciated that. And it's been working out really well.
Good. I'm going to give a shout out to Jan and Kathy and Colleen and Orlando and Lindsay, the folks that kind of do some of the behind the scenes work, and actually not always behind the scenes. There's some of the folks when you show up to the rehab building that they're right there seeing you. So I want to give a shout out to those folks as well.
Yeah.
Very much.
Okay. So last question. Okay, folks have been watching you, Drew and Allie, and I think I was going to ask Drew this question. But they've been watching this program and they're like, you know what, this sounds interesting. I might be interested in doing that. Either they might be interested, or someone who's watching has someone that they can think of in their life who might be interested in getting into physical therapy, or let's say occupational therapy or speech therapy as well. What does that look like? And if they're, can you give some information about that and what people want to kind of begin to do if they want to pursue that kind of career?
I would say it starts pretty early. So you start trying to think about what you want to do in high school, but obviously that's a pretty difficult age to truly make a decision. But I started doing a lot of just PT observation with local physical therapy clinics when I was in high school. Spent a lot of time bouncing around in different settings. I observed pediatrics. I did home health, inpatient and outpatient, all trying to decide if this was really a field I wanted to go into. And when you do, it's 4 tough years in your undergraduate degrees, primarily in the sciences. Common majors would include athletic training, biology, psychology, or an exercise science of some sort. Once you've completed those 4 years of undergraduate degree, along the way, probably also doing more observation hours or clinical of some sort, you then apply to a 3-year postgraduate doctoral program. So all in all, it's a 7-year degree. Depending where you go or how you fit your program, they may do it in 6 years and some even 5.5 if you're able to do a fast track. But usually it's a 3-year doctoral program for the actual physical therapy after your undergraduate degree.
Okay.
For the occupational therapy, very similar. You do your undergrad, and then you would progress into a master's degree, which can be anywhere between 2.5 and 3 years, depending on the school. And as far as I know, speech would be the same. So still a master's degree following that undergrad degree. So.
Sounds good. Thanks, Drew.
Yeah.
Let's get Allie back on here too. So Drew and Allie, thank you. Been very helpful to have you, both of you, on here to answer some questions for folks who are watching this program. And I want to thank you both for all the great work you do in our rehab department.
Oh, thank you.
Thank you.
All right, guys. Well, take care and have a good, hey, this is just the beginning of physical therapy month. So we hope you have a great month.
It's a big month.
All right. Take care.
Thank you.